Good evening, everyone. Welcome back to Toxicology series. So, as you all know, we have started our toxicology series 2 days back. Our first session was on topic of pros and cons and patient. Dr. Jeevan took a very wonderful session. He gave a lot of tips and in the mornings how to answer the exam oriented questions. And so today we are going to discuss about benzodiazepines and barbiturates. So it's my pleasure to welcome Dr. Sreejith, who is currently working as a consultant at Amala Institute of Medical Science. His MD in emergency medicine. Welcome, Dr. Sreejith. Sreejith, to begin today's session. Over to you, sir.
Am I audible? I guess there was some issue with the network in the beginning. Am I audible? Can somebody please
Yeah,
respond?
you're audible. You're audible. Yeah.
Yes. Thank you. So this will be our second session on the Toxicology Edge Toxicology online series, which EM-PACT is conducting. And today we will start with the individual sessions on toxicology topics. In the first session, as we know, we learned about the general approach to toxicology patients. And today we'll start with the one of the most commonly used drugs in our emergency department. I hope out of the 30 participants which we are having, almost all of them are emergency physicians. So left, right, Monday to Sunday, we use benzodiazepine in our emergency. Midazolam, lorazepam, diazepam. We tend to use that every day. So have you ever thought what happens when you overdose a patient, or what happens when a patient who is actually taken tablets of midazolam, tablets of lorazepam, who comes to an emergency in an overdose case? So how do we manage those patients? So before going into management, I would like to start with the basic pharmacology of this benzodiazepine and barbiturates. So let's move forward and see the pharmacology sessions. So if I want all of you to imagine that you are taking the driving license, learner's driving license. So we all have done that when we are 18 years of age. And we always have this instructor who is sitting beside us, and he has a brake on himself. The person who is riding the car has a brake, and the instructor who is taking the car, who is teaching us, will also have a brake pedal to himself. So it is the same mechanism how the GABA receptors works. So GABA is a receptor which, when you are stimulating the GABA receptor, it actually helps in the hyperpolarization of the chloride channels, and the chloride channels open, and postsynaptic, in the post synapse, what actually happens is hyperpolarization happens. So the neuron which is actually going at a fast rate, just because the brake has been applied, there is some kind of inhibition that is happening normally. So what this benzodiazepine does is that benzodiazepine increases the frequency of opening this chloride channel. So we have two type of instructors. One which lets us drive peacefully, one who doesn't let us drive. So benzodiazepine belongs to that category who lets us drive peacefully, because it increases the opening of the frequency of opening of chloride channels. Whereas if we compare that with the barbiturates, it actually prolongs the duration of opening of the chloride channels. So one happens in the frequency and the other happens in the duration of opening of chloride channels. So why are we using more commonly? I believe that I was talking to one of my anesthesia friends recently, and I asked him whether do you guys use barbiturates these days, and he told me that it depends upon the center where the person is working. Some centers still prefer barbiturates for the inducing, as an inducing agent, and over this, if you compare the history from 1980s to 2026, the use of barbiturates has consequently declined, and people for procedural sedation and cyanotic activity, they tend to use more of benzodiazepine, and even in emergency, we tend to use more of benzodiazepine. It is because of this effect. This effect is known as the ceiling effect. So if you dig deep into the pharmacology of benzodiazepine and barbiturates, what happens is that the benzodiazepine, it actually depends upon the intrinsic GABA amount that is already present. If the GABA activity is not there, benzodiazepine cannot act beyond an extent. So there is this GABA ceiling effect, which makes it much more safer when you compare that with the barbiturates. And this GABA ceiling effect is broke by barbiturates, and which leads to overdoses and unpredictable drug reactions when you use barbiturates. So this is a basic difference between the pharmacology of benzodiazepine and barbiturates. Now, where do we use these benzodiazepines? Benzodiazepine, as we know, for procedural sedation, we use it on a daily basis in our emergency. It has some hypnotic effects. It also has some anxiolytic effect. It is an excellent amnestic. It is also used as an anticonvulsant, and it also has some muscle relaxant property. So there are n number of uses where we can use benzodiazepines. And what about stimulants? Suppose you have a patient who has amphetamine or is cocaine intoxication. And what about that? If the patient is presenting to you in a seizure, which is a drug of choice for a stimulant toxicity or a serotonin syndrome? Yes, of course, there also we can use benzodiazepine as the foundational therapy. Why benzodiazepine is used in, we'll come to all serotonin syndrome, stimulant toxicity in the subsequent toxicology sessions in this month itself. So what benzodiazepine does in those conditions is that benzodiazepine reduces the central sympathetic outflow. It lowers the blood pressure. We all know some sympathomimetics like cocaine, amphetamine, they increases the heart rate, they increases the blood pressure. So benzodiazepine, they lower the heart rate, lower the blood pressure, and also lowers the agitation associated with cocaine or amphetamine toxicity. And also for alcohol withdrawal symptoms, the drug of choice is benzodiazepine. We prefer diazepam, and if the patient is having severe liver diseases, lorazepam is also preferred. The why lorazepam is better preferred is because am I audible right now? Yes.
Audible. Yeah.
Okay. Thank you. So let us compare these three commonly used drugs, midazolam, lorazepam, and diazepam. Midazolam, if you see that the onset of action is almost, if you compare these three, the fastest onset of action is for midazolam. It is 1 to 5 minutes, and it is easily available as IV, IM, intranasal, and also buccal roll. Lorazepam, the onset of action is almost 15 to 30 minutes. It is the slowest, whereas diazepam is 1 to 5 minutes, almost all equal as the midazolam. And the duration of effect is where the actual key lies, where if midazolam, it actually lasts for 1 to 2 hours. It is extremely short acting, whereas lorazepam and diazepam has a much longer half-life. Like lorazepam is for almost about 6 to 10 hours, whereas diazepam is for 2 to 6 hours. And this is just for an statal epilepticus dose. We have a milligram per kilogram dose, but it is just for the completion sake, I have given midazolam. We can give 10 mg IM. Usually the vial comes about 1 milligram, 1 ml will be almost 5 mg. We always give 1 ml as a beginning, and then we can give 2 ml if the seizure further persists. And lorazepam, the dose is 4 milligram. We start at 2, and then we can escalate it up to 4 milligram, and diazepam 5 to 10 milligram. And the procedural sedation is also given in the table. I will definitely share this PPT in the group after the class is over. So this is just a comparison where we can compare midazolam, lorazepam, and diazepam with each other. So let us see a clinical case. Suppose a patient who was there, who was taking midazolam for, suppose, a clinical condition, and he accidentally took around 7 to 8 tablets of midazolam, and he presented to an emergency. And on your examination, you found out that the heart rate was 63, the saturation was 96, and the respiratory rate was fine, and BP was on a bit of lower side, yes. And you examined the patient and found out that the patient was lethargic and minimally responsive, but the pupil were reactive. This is one common case which we get in our emergency. Yes. So you examine the patient, you check for the respiratory sounds, you found out that the patient was shallow breathing, but the breath sounds were almost vesicular on both sides, and you found out that the ABG, you took an ABG, and you found out that there was a respiratory acidosis associated with the patient. And in your primary assessment, you come to the conclusion that it is something he might have overdosed with the benzodiazepine. Yes. And there is primary CNS depression because the patient is lethargic, and it is associated with some secondary respiratory acidosis, and patient might end up in hypotension, frank hypotension, if we are not acting properly immediately. So how will you manage such patients in an emergency? Let's move forward. So how will a patient who has taken benzodiazepine, or who has been given an IV rapid IV push of benzodiazepine, present with symptoms of toxicity? As we know from the as I started with the pharmacology, we know that the primary effect of this benzodiazepine is keeping the brain from hyperexcitability. If there is no benzodiazepine, if there is no baseline gamma activity, the brain will have its hyperstimulation, and there will be seizure happening. So if there is benzodiazepine at a minimal lower level, this is where I was talking about the breaks in the initial session. If the brakes were applied normally, what would have happened? The brain would not have hyperexcitability, and the brain would be in a normal state. Brain would not have precipitated seizures. So what happens in toxicity? What happens in toxicity is exactly where the brain goes into a negative state, where the patient will present with somnolence, confusion, androgate amnesia, and the cerebellum might get affected. The patient might have incoordination in walking, ataxia might be there, the patient might present with nystagmus, there will be slurring of speech and dysarthria. So if you read this brain, cerebellum, mouth, and throat symptoms, it is actually a stroke mimicker. So once the patient who comes to an emergency with all these kind of symptoms, if you're thinking in the stroke pathway, and if you're going for an MRI protocol, and if it turns out to be normal, always keep in mind about the toxicological aspects which might be there in such patients. And also, as you know, benzodiazepine we always do this. If you are giving a midazolam for the patient who is agitated in a CT console or something, we ask the staff to give midazolam 1 ml or something. But we always ask them to monitor the saturation or keep the patient on nasal prongs or a face mask. Why? Is because benzodiazepine also acts on the respiratory center, and there will be respiratory depression or hypotension associated with this case. So the clinical case which I was talking earlier actually was having was an early hypotension. So how will we manage these kind of patients? So what about, I talked about in the beginning session that benzodiazepine actually is having a ceiling effect. And why are we worried about benzodiazepines? Can benzodiazepines alone cause this much of lethal respiratory depression? So what dictum states is that if you refer almost all the standard textbooks of toxicology, they always have this concept where benzodiazepine, the patient who is intoxicated with benzodiazepine, there is always possibility that there might be overdose with some other drugs also. So when you combine this benzodiazepine with something that is almost dangerous as benzodiazepines, like the opioids, ethanol, or barbiturate, if you're combining benzodiazepine with barbiturates, opioids, or ethanol, it can lead to lethal respiratory depression. So once you decided to treat only the benzodiazepine aspect, there is no chance that your respiratory depression is going to recover. So always keep in mind about the co-ingestion along with the benzodiazepine, because once there is co-ingestion with the benzodiazepine with these three drugs, it can lead to severe increase in the morbidity and mortality, because opioids also act on the mu receptors, alcohol again acts on the benzo-GABA receptors, and barbiturates again act on the GABA receptor. So these can lead to severe lethal respiratory depression. This is one thing to keep in mind when you are dealing with benzodiazepine toxicity patients. So what about urine toxicology? We always get patients who was kept in ICU in other hospitals, who was given midazolam, fentanyl infusions for long-term sedation. And we usually get these patients who is in prolonged altered mental status. So once we send the urine toxicology level, it comes out to be positive. So what does it actually mean? So is there any role of sending urine toxicology acutely from the emergency point of view? So it is actually the serum levels actually do not correlate with the clinical state. That is what is said in textbooks. And if you see that the urine toxicology, for once you test it, it is more specific. They actually screen the metabolites, that is the oxazepam, no diazepam, tamazepam, and they do not screen the parent compounds. And also
Mm-hmm.
there is high chance that there will be false positive and false negatives happening. So if the patient is on some drugs like the SSRI or oxaprozin or sertraline or oxaprozin, there is always chance that the urine toxicology might cross react and become false positive, and there is chances that it might become false negative also. And in some of the conditions, there has been case reports where the urine toxicology has missed midazolam and lorazepam infusions for long-term infusion. Even the urine toxicology has turned out to be negative. And also suppose the patient had an for some condition, the patient had an intake of benzodiazepine 30 days back, and because of the long acting agent, some example, it was a drug which was having a long T half time, and you send for the urine toxicology and it turns out to be positive, but the patient might have ended up in an emergency with another cause of an altered mental status. So there is no relation between correlating with the urine toxicology and the acute AMS right now. So urine toxicology has in a benzodiazepine toxicity has a limited value, yet we send a urine toxicology, but we do not wait for the urine toxicology reports for starting the emergency management of this patient. Of course, yes, for documentation purposes, you can send urine toxicology, but we do not wait for the results to start our treatment. So there is some terms which is associated with benzodiazepine toxicity. This was often asked in almost all of the board examination viva sessions, where the exam going PGs, they usually have this session of drug, and once you take the midazolam or any other benzodiazepine vial, they usually ask these questions. So what is the paradoxical agitation? Can benzodiazepine only cause CNS depression, or can the patient become agitated? So the answer is yes, because the exact mechanism why this agitation happens in a benzodiazepine toxicity is not known. They believe that once beyond an excess level of benzodiazepine toxicity, the GABA ceiling effect is entirely lost and the patient become agitated. And it is usually seen in elderly people who has been taking long-term antihypertensive anti-diabetic medication, who is on a lot of drugs because of some drug interaction. The exact mechanism is not clearly given in literature, but yes, there is a possibility that the patient will not be going into a negative brain state, but might present in a paradoxical agitation. So that is also seen in benzodiazepine toxicity, not always seen. It is seen in almost around 5 to 10% of the cases. So paradoxical agitation is one term which is usually asked in viva examination. And in suppose we have patients. This has happened to us when we were in our PG time. For one indication, the patient was in ICU and the patient was started on infusions of lorazepam. And after a few hours, by the infusion was started in the morning, and by in the evening and by night, when we took the serial ABGs, the lactate level was found to be serially increasing. It was initially 3, it then turned out to be 4.6, then it became 9. And we were actually looking for reasons why these lactate levels are persistently increasing. We were thinking of shock, other causes of why the lactate might increase. And finally, one of our seniors told that this diazepam and lorazepam, they have in their parenteral preparation, there is a diluent called propylene glycol. Propylene glycol is there. And once you exceed this IV infusion dosage of more than 1 milligram per kilogram per day, this propylene glycol can actually cause lactic acidosis and severe high anion gap metabolic acidosis. Once you do not know this cause of propylene glycol leading to high lactic acidosis, we will always look for other causes why the lactate is keeping on increasing. So once we stop that patient on lorazepam infusion, and the patient actually, the lactate level came down in 2 days. So this is again another viva questions which is usually asked. Diazepam and lorazepam has this diluent known as propylene glycol, which can cause lactic acidosis and even nephrotoxicity. There are case reports where, because of prolonged infusions of lorazepam, the patient went into acute kidney injury and hemodialysis was required for this patient. And also, if you are suspecting propylene glycol toxicity, there is always an option, because propylene glycol is dialysable and can be removed by hemodialysis. So how do we manage this benzodiazepine toxicity? Of course, being an emergency physician, we follow A, B, C. In an airway, if we position the patient appropriately, we routinely check for any secretions, we keep the airway pattern, and if the GCS is less than 8, we tend to intubate this patient. This is what something which we all of us can manage. Breathing, if the patient is hypoxic, we supplement the patient with oxygen, and if the patient is hypotensive, in our case, as we have discussed in the beginning, the patient was going into hypotension, so we'll start the patient on IV fluids. And if the BP is not picking up, we can always have this option of starting vasopressors, and if the shock is persisting. So if you go across Tindin Alley or any other textbooks of toxicology, we always have this in almost all the toxicological cases. A, B, C remains the same. It is only the difference where we only in few toxicological cases we have a definitive antidote, or in some of the cases we give enhanced elimination technique. Enhanced elimination techniques was in detail discussed in the first session by Dr. Jeevan. Yes, and here also in this benzodiazepine overdose, if the patient actually presented within 1 hour of ingestion, we can always opt for activated charcoal. And activated charcoal, 1 milligram per kilogram dosage is given, with maximum of 50 milligram is given. And also along with that, we have to exclude the other co-ingestions, like if the benzodiazepine along with an opioid, if an opioid is there, we will always consider for an naloxone, barbiturates, and also if the alcohol intoxication was also there, we manage the patient a slight bit differently than pure benzodiazepine overdose. We also take the ECGs, we look for the QT prolongation, we check the blood glucose level, and also for the ABG. Why ABG? Because you can always think about the propylene glycol diluent toxicity that might happen, and the elevated lactate levels, which is seen in hemodynamic instability. So, is there any role of forced diuresis, MSS induction, or any hemodialysis or hemoperfusion? No, there is no role of any forced diuresis, no MSS induction. Or if the patient, if you are actually suspecting propylene glycol toxicity, then we can go for hemodialysis of the patient. Why is not hemodialysis done in this benzodiazepine? Because it has a large volume of distribution, and also it is highly lipid soluble. So these drugs are not dialysable, and so we cannot remove it by hemodialysis. So hemodialysis is not the treatment of modality in benzodiazepine toxicity. So in isolated benzodiazepine overdose, I am again stressing on the point. In isolated benzodiazepine overdose, supportive care is usually sufficient, and mortality is exceedingly low. So after listening to this lecture, you might be wondering why I have not mentioned about the drug which you all have been learning for a long time. It is our favorite MCQ question. The antidote for benzodiazepine toxicity is flumazenil. I have purposefully not mentioned about flumazenil till now. Why? Because let's see about a bit in detail about the flumazenil. Flumazenil, it is actually, what is the mechanism of action? It is a competitive antagonist at the benzodiazepine receptor. So this benzodiazepine, they go and bind to the GABA receptors, and flumazenil, it is a competitive antagonist at this benzodiazepine receptors. And it is usually given as dosage 0.2 milligram over 15 seconds, and we can repeat it every minute, and the maximum dosage is 3 milligram. And have you ever wondered what is the what is the T half of a flumazenil IV shot? So it is only 1 hour. So what if the patient has taken a benzodiazepine which is acting for almost 10 hours? What happens after this flumazenil effect wears off after 1 hour? 1 hour. That is exactly the reason why the usage of flumazenil is not recommended these days, because the duration of action of this flumazenil is extremely short when you're comparing that with the duration of action of the benzodiazepine, and there is always a chance for recurrent toxicity and resedation once the effect of this flumazenil wears off. And along with that, there is another risk which is associated with flumazenil IV. So imagine that the patient was given benzodiazepine. Imagine that the patient was given benzodiazepine, and the patient is actually in a depressive state of mind. The CNS has gone into negative effect, and you suddenly reverse every negative effect that was there in the brain with the flumazenil. So what happens? the brain again goes into hyperagitation, and there is a chance that the withdrawal, precipitation, and refractory seizure happens. So there is a very high risk of flumazenil induced seizure that is seen in benzodiazepine toxic cases. So because of this high refractory seizure, and these seizures tend to be extremely refractory, it doesn't settle on your usual anti-epileptic drugs, and it usually requires barbiturate infusion or propofol infusion to get these seizures down. And because of this massive risk, flumazenil is not usually recommended these days. And there is, yes, there is definitely benefit if you know, if you definitely know that the drug taken was only the benzodiazepine, there was no other co-ingestion associated with it. And if it was an electronic procedural sedation, suppose you're given an IV and a direct, if you are in an emergency for a procedural sedation, if it was a very low dose, the patient was not a dependent of benzodiazepine, you can always try flumazenil, but it has only a very narrow benefit, and there is a massive risk associated with using flumazenil. So this is what happens. The cerebroprotective effect is there. If you are starting the benzodiazepine as an anticonvulsant effect, the cerebroprotective effect is there. And once you administer flumazenil, the entire cerebroprotective effect is veered off, and you have refractory withdrawal seizures that is happening. And usually, because both of them act on the same receptors, for the flumazenil induced seizure, the drug of choice is again phenobarbital or propofol. This is again another critical care MCQ question. The drug of choice for flumazenil-induced seizures is phenobarbital or propofol, not your usual anti-epileptic drugs like Eptoin or Levipil. So where is flumazenil actually contraindicated? Where are we not supposed to use flumazenil? Definitely in cases where there is overdose of unknown agents, we are definitely not supposed to use flumazenil. And if there is any if the patient is actually dependent on benzodiazepines, again, because it can trigger seizure and severe withdrawal can be triggered. So if the patient is actually a benzodiazepine dependent patient, we are not supposed to use flumazenil. And again, in patient co-ingestion of seizure-inducing agents, the reason was explained right now. And again, if the patient is a known seizure disorder, because the seizure threshold is lower and the patient might end up in refractory seizures, if flumazenil is given for those patients. And also in raised ICP patients, raised intracranial pressure, where there is severe head injury, can have adverse effect on the cerebral hemodynamics in this patient. So this is just the mechanism of benzodiazepine withdrawal. I'm just not going to details about this. Just like alcohol withdrawal symptoms, so if you check if you go into details about the alcohol withdrawal, the symptoms usually present in the first day, it gets aggravated on the second day, and ends up in delirium tremens on the third day. But what about benzodiazepine? What happens in benzodiazepine is that benzodiazepine withdrawal effect actually depends on the duration or half-life of the drugs which the patient has been dependent on. So suppose it was a short-acting drug, the 2 to 3 days drug, the effect immediately comes after 2 to 3 days. What if it was a long-acting drug? If it was a long T-half drug for which the patient was abusing, the withdrawal symptoms actually happens 5 to 10 days later. And these are some of the neurological and psychiatric symptoms which can happen in benzodiazepine withdrawal symptoms. And people usually say that, again, I could not find a specific reason for this alprazolam exception. And the withdrawal symptoms and withdrawal rates tend to be very large in this alprazolam abusing people. And the exact reason why alprazolam causing this effect is not known, but this is one of the reasons why alprazolam is not prescribed these days, even by psychiatrists these days. So just summarizing the benzodiazepine effect. Benzodiazepine, it has an excellent usage in status epilepticus, alcohol withdrawal, and for procedural sedation. And in an emergency department, we tend to use this midazolam, lorazepam, and diazepam. It has a built-in safety effect for its own because of the GABA ceiling effect, which I talked about in the beginning. But there is a threat if the patient has co-ingested opioids or alcohol along with the benzodiazepine overdose. And in all cases, the treatment is not always flumazenil. It is basically the treatment is supportive, and in only very rare cases, we tend to use the flumazenil because of all the side effects associated with flumazenil and also the large list of contraindications. The contraindications for flumazenil, the pharmacology of benzodiazepines, and also the use of benzodiazepine as a procedural sedation drug was asked multiple times in board central examination. So the exam going students, please make sure of this high yielding area. So a few notes about some of the recent drugs, some of the another benzodiazepine drugs which are used for sleep other than the benzodiazepines, which we commonly tend to see in an emergency department where people comes with an overdose is the Z drug. Z drug, some of the Z drug, if you want me to name them, it is Solpidem, Zoliplam, Zopiclone, all these drugs. And again, it acts almost similar to the benzodiazepine, and it again acts on the GABA A receptors, the exact same receptors where the benzodiazepine act, but it specifically binds to the alpha 1 receptors. That is the BEZ1 receptors of the GABA A receptors. And why the Z drugs has become more of a favorite part for the physicians is because benzodiazepine, what actually, if you're prescribing benzodiazepine for a patient who is sleep deprived, it actually crushes the REM sleep. Rapid eye movement sleep is crushed by benzodiazepine, and it increases the light stage 2 sleep. Like you will be always, there is a bit of awakeness within you when you are taking benzodiazepine, and the next day people, if you talk to people who has been taking benzodiazepine for sleep, if you ask them, next day there will be the cognitive impairment in them. They will be tired, they will not be able to perform to their full. But if you compare them with the benzodiazepine with the Z drug, it actually preserves the REM sleep, and it is a better subjective sleep quality if you compare that with the benzodiazepine. So that is why these days Z drugs are more used. And the Z drugs, again, it has excellent clinical safety. Along with that, there is a black box warning. Definitely, there is black box warning of parasomnias associated with it, like sleep driving, sleep eating, cooking while asleep. All these are associated, some of the parasomnias associated with Z drug, but it has excellent safety. And even if you, what dictum states is that if you take 10 tablets, suppose the patient has abused even 10x times the normal dose, there is no severe respiratory depression associated with this ESET drugs. So it is of excellent clinical safety, and we usually, the main management is supportive management. So again, since ESET drugs are acting on the benzodiazepine receptors, are we supposed to use flumazenil? Can flumazenil reverse the ESET drug? Can it reverse zolpidem? Actually, it can reverse this ESET drug effect, but it is again not preferred because supportive care has shown to have excellent benefit in the treating ESET drug overdose, and also there is a risk of seizure, which the reason was already explained earlier. So we do not use flumazenil even in ESET drug overdose. And and there is yet another classic category of drugs which is very popular these days. That is the melatonin drugs, which is given for sleep. And if you see that melatonin drugs like the ramelton and tasimelton, there is excellent safety margin in these drugs, and it is associated with minimal dependence, and there is actually very minimal withdrawal symptoms associated with no almost zero respiratory depression in patients. So it is again commonly used, and patients, it is excellent safe. There is excellent safety for this melatonin and ramelton in old age people. And if there is an old 80-year-old grandmother who's looking for some sleep, then you can always prescribe melatonin and ramelton. So again, this act on the melatonin 1 receptor, melatonin 2 receptor. I'm not going to details about going to details about all these melatonin receptors. Just know that there is a category of drugs called melatonin drugs, which is of excellent safety. And even if you get patients who is in overdose with melatonin drugs, the supportive care is always the management. So this is just a comparison table of benzodiazepine, ESA drugs, melatonin drugs, and antihistamines. Yes, antihistamines is one category of drugs which is extensively abused over the counter for sleep. We all know that. And if you compare these with other drugs, the dependency risk is extremely low, but the overdose severity is extremely high in antihistamines. And The definitive antidote, if you ask me, the definitive treatment for benzodiazepine toxicity, it is definitely supportive care, but there is an option for flumazenil, but with again extreme caution. ESA drugs again, the same mechanism of action, but the receptor is a slightly different, the alpha 1 receptor of GABA. The antidote flumazenil is always there, but it is usually not recommended. And melatonin drugs, usually the treatment is supportive care, and antihistamines. Yes, I'm not going to detail because this session will come as a separate class in your coming in this month itself. So that is about antihistamines. So coming to the second half of this session, where I'm going to discuss about the barbiturate toxicity. So why is barbiturate toxicity important? Yes, because we get these patients in emergency, and also for the exam going PGs who are listening, phenobarbital was asked multiple times. It was asked for the last 2 years, I guess. In the last 3 years DNB exam, phenobarbital toxicity was asked 2 times. It was a repeated question for the AIMS Delhi board examination and also for the JIPMER board examination. Phenobarbital toxicity was asked multiple times. So, as I talked about in the beginning session, are we using barbiturates that much compared to the benzodiazepine? The answer is no, because uh, there is always a higher risk associated with barbiturates because the drug predictability, because the drug effect is not that predictable. We always tend to find, as an emergency physician, I always found benzodiazepine much safer to use than barbiturates, and also the number of uses for which I can use barbiturates in an emergency setting is limited. So, and if you compare the history, this was what I was talking about in the beginning. If you compare the history from over the 1930s to almost 2000, the usage of barbiturates has significantly reduced, and we found much safer drugs with much predictable drug interaction over these years, and we are using those drugs much more compared to barbiturates. Yes, there are definitely uses of barbiturates, and let's see what historically they have been used for n number of uses, but now the usage of barbiturates are extremely limited. And in neurology, it is used for refractory status epilepticus and toxicological seizures. So remember, toxicological seizures where phenobarbital I was talking about earlier, where flumazenil induced seizure, you can always use a barbiturates. And also in critical care patients where elevated intracranial pressure or diffuse traumatic brain injury, where you want a brain to go into a negative effect. And if for pain management, it is always used as a combination medicine for tension and migraine headache. It's always usually in the refractory cases, and also in veterinary clinics, laboratories, and also for euthanasia, it is easily available and used in veterinary clinics and all. And we usually, there has been, if you compare uh, cases of patients where a medical professional has gone into a deliberate self-harm, there has been excessive case records in the last 3 or 4 years where patient has abused barbiturates often. So this is again, if you ever get a patient who is in barbiturate toxicity presenting to an emergency and you need to act fast, let us see how to manage these patients. This is again another pictorial representation where I've tried to explain how the mechanism of action of benzodiazepine and barbiturates are different. Benzodiazepine, it increases the frequency of opening of the chloride channels, whereas the barbiturates, they increase the duration of opening of the chloride channels of the GABA receptor. So as a result of increased duration, there is prolonged depolarization. So what happens when there is prolonged depolarization? There is prolonged cellular inactivity and there is profound CNS depression. The exact same reason why barbiturates are not used commonly these days. So, if you check the old pharmacology books, they always try to divide the barbiturates as ultra short acting, intermediate, and long acting. Historically, barbiturates were classified as that. So, is there any role if suppose a barbiturate intoxication patients, barbiturate toxicity patients present to emergency, will we classify it as ultra short, short, intermediate, and long? The answer is there is no um, role of classifying it as based on the duration of action, because what actually happens is that these barbiturate drugs are highly lipid soluble agents and they tend to cross the blood-brain barrier extremely fast, and it gets there is an actually, because it gets modulated by the CYP450 enzymes, it actually undergoes enterohepatic circulation and is extreme. It is redistributed so fast in the body, and even short acting drugs can become have a long acting toxicity. So that is the exact reason why we do not check if the drug is short acting, intermediate acting, long acting, because the mechanism of distribution is so fast that so that even the very short acting barbiturates can present as a long-term toxicity in intoxication cases. So again, the symptoms of benzodiazepine and barbiturates are almost same. It has a negative effect on the neurological aspect. The patient might be in drowsiness, ataxia, slurred speech, stupor, or coma. There will be cardiovascular collapse, exactly the same as benzodiazepine toxicity, and there will be respiratory depression and GIT effect associated with it. So once you get this patient, how are we supposed to examine them? In the neurological aspect, we can check for the deep tendon reflexes, we can check for the corneal reflexes, we can check for the brainstem reflexes. And actually, if you there is a criteria for defining brain death. So if you are trying to declare a patient brain dead, there are a number of mimickers which you have to exclude before declaring the patient brain dead. So one such criteria is where the patient should not be on barbiturates. So barbiturates can actually mimic brain death, and you have to exclude that before declaring the patient as brain dead. And so there are some of the dermatological clues which can point if it is a barbiturate toxicity or not, but it is not usually seen. They have given internally, they have given a fancy name known as barb blisters, indicating barbiturates blisters, but it is very rarely seen. And why it is named so that because patient who is in barbiturates intoxication usually lie unconscious, and there will be pressure. So pressure points, there will be bed sores or the blisters happening in the pressure point. So they gave a fancy name to those pressure point bulle or blisters, and it is known as barb blisters, which is some of the dermatological clues which can find in barbiturate toxicity patient. And also, since it is having a depressive effect on the bowel, always check the bowel sounds, and also think of the paralytic ileus that might be there. So once you get a barbiturate patient, what are the blood tests which we are supposed to send from an emergency? We always check the blood glucose. Blood glucose and ABG, it is always done as part of our primary survey and an adjuvant of primary survey. And we get an ECG done for the patient. We assess if there is any cardiac ischemia or any cardiac insult that is there, and also ECG. From the ECG, we can always get a clue where there is any other co-ingested which can cause a QT prolongation or other specific changes which can be found in an ECG. And we send the blood counts, lactate level, and CPK if there is any chance of rhabdomyolysis in the patient. And again, just like benzodiazepine, is there any role of sending an urine toxicology? Urine immunoassay, usually they tend to be false positive, especially with other drugs like Crows react with ibuprofen, naproxen, and serum levels are highly variable, and we usually do not wait for the urine toxicology results to start the treatment. And yes, of course, for completion's sake, we can definitely send that from an emergency department. So how are we supposed to manage this patient? We go with the basic principle. There is actually no specific antidote for the barbiturate. So supportive care is almost always the basic treatment. We maintain the airway, we maintain the breathing, we maintain the circulation. We start with fluid, we monitor the urine output, and if the BP is not improving, we can always start on escalate to vasopressors. And also temperature control should be done. And if the patient is hypothermic, we have to go for aggressive active external rewarming techniques should also be adopted. So you admit the patient, and for 6 hours you monitor the patient, and you found out that the patient has improved neurological status, the patient's vitals has been improved. And then there is a safety line, and yes, of course, definitely you can discharge the patient after 24 hours. And after 6 hours, if the patient is having clinically, if you are clinically monitoring the patient, and if the core temperature is going down, the patient cardiovascular instability has developed, then it is time for further management in an intensive care unit. And definitely there is, at this point, there is no antidote we can give. All we can do at this point is think of the supportive care. We can strengthen more of supportive care. So what is the role of activated, or is there any role of activated charcoal? And if the patient who has presented with an oral injection, acute oral injection within 1 hour, we can definitely give activated charcoal for this patient. And is there any role of multi-dose activated charcoal? This multi-dose activated charcoal session was taken in the first session. Is there any role? Multi-dose activated charcoal, what actually happens is that it is usually given for long-acting agents. And in barbiturates, one of the long-acting agents is the phenobarbital. The specific drug was asked multiple times, phenobarbital. So yes, in phenobarbital toxicity, there is always a role for multi-dose activated charcoal. And how are we supposed to do that? We start with an initial dose of 50 milligram. We give via Riles tube, or we can ask the patient to drink if the patient is fully conscious oriented. But usually we give it via Riles tube. We can give it as 50 milligram. Then for every 4 hours, we usually give 12.5 to 25 grams per oral we can give. And there is no role of forced cathartics or any other forced MSS. There is no role of all this treatment. And we have to continuously monitor the patient. So this is just a summary of how we are supposed to manage um, if the patient is deteriorating. Yes, if it is a long-acting agent like the phenobarbital, we can always consider multi-dose activated charcoal, and also hemodialysis is also an option in phenobarbital long-acting agents. But if it is a short or intermediate acting, there is no option for multi-dose activated charcoal or hemodialysis. We have to maintain the supportive care, and there is no role of forced diuresis and urinary alkalinization. If you check online published papers, you can see that earlier there used to be, they used to claim that there is some role of urinary alkalinization in a barbiturate toxicity, but not recently. They have almost told that there is no role of any urinary alkalinization technique. It is proven of no benefit, and it is not used these days. And this is the reason why for phenobarbital, this multi-dose activated charcoal and hemodialysis works, because if it is if phenobarbital is actually a long-acting agent, it can actually pass through because of the low protein binding. It can actually pass through, but if it is a short-acting agent, it is extremely highly protein bound. You cannot pass through the dialysis membrane or whatever the or cannot get absorbed. So that is why short-acting agents, we cannot use multi-dose activated charcoal or hemodialysis. So this is again a summary table of barbiturate toxicity. Again, barbiturates, what happens is binds to the GABA A receptors, increases the duration of chloride channel opening. Just to refresh, the benzodiazepine was actually increasing the frequency of benzodiazepine GABA receptors. And the diagnosis is actually clinical. Hypotension will be there, hypothermia will be there, altered mental status will be there. Beware of the false positive urine screen, both in benzodiazepine and barbiturate toxicity. And we do not wait for the serum levels for our resuscitation to begin. And for both benzodiazepine and barbiturates, aggressive supportive care is definitely the treatment A, B, and C. And we have this option of flumazenil, but it comes with a lot of contraindications and risk associated with benzodiazepine while we are using flumazenil. And for barbiturates, almost always the option is supportive care and elimination. No forced diuresis. Alkalization is now obsolete. And for long-acting agents, phenobarbital, we can always definitely consider multi-dose activated charcoal, and hemodialysis is always an option in long-acting agents like phenobarbital. So now we have come to the end of the session. This was actually a very short session, and I could have ended the session in actually 5 slides, where I could have told that benzodiazepine and barbiturate toxicity is basically supportive care, and flumazenil comes with a lot of contraindication. But I just wanted everyone to know the reason why flumazenil is not given routinely, and the contraindications and all of this. And it is actually a very high yielding exam topic, because this phenobarbital benzodiazepine pharmacology has been asked n number of times, and also it is a very favorite viva question. The mechanism of action of midazolam, lorazepam, diazepam, phenobarbital is a favorite viva question also. So all the exam going PGs, make sure you dig a little deep into this pharmacological aspect. And thank you. If you have any questions, please be free to ask in the WhatsApp group or in the comment section. I guess that's it. Over to Anne.
Thank you, Dr. Sreejith, for the wonderful class. It was a great stretch of concepts that you have told to us. So the whenever we hear about the benzodiazepine poisoning, we always think about flumazenil. But it was a great insight that you gave to us that flumazenil comes with lots of contraindications, and we don't always give the flumazenil for a benzodiazepine poisoning. And regarding the barbiturate poisoning also, there was a great stretch of concepts you gave. Hope everyone enjoyed the session. Thank you, Dr. Sreejith, and thank you, participants. We'll be seeing with other session.